We'll move to a final presentation, and Dr. Albert Alahmar, Senior Consultant Interventionist from Sulaiman Al Habib. Does CABG harden native coronaries, Hybrid CTO LMS through vein graft?
Thank you very much, Dr. Abdullah, and thank you for staying. I know it's a bit late for everybody, so it's a great meeting. I'm sure we all agree that we enjoyed the meeting. I'll just go through the case briefly so we don't delay the time. This is a 61-year-old gentleman, high risk profile as most of our patients, diabetic, hypertensive, treated dyslipidemia. In 2003, had a bypass graft surgery, the usual Lima to LAD, 2 vein grafts. Presented to us with angina, CCS class 2, class 3, despite 4 anti-anginal treatments. He did have a stress echo which showed lateral ischemia around 15 to 20%, so quite significant ischemia. He was referred for revascularization. This is the angiogram, the diagnostic pictures, and as you can see, he's got a pure stump in the left main stem, not much beyond that point. His right coronary artery was occluded mid-vessel after a small marginal branch. So native vessels, not much to play with. His Lima was patent, as often the case, with reasonable runoff distally. This is a vein graft to his PDA, which fills retrograde the circumflex, and I'll show you the better picture showing this collateral towards the circumflex and obtuse marginal. But after a lot of discussion, MDT meeting, I won't go through all this. The agreement was to perform a PCI to his circumflex into left main stem. And in a show of hands, obviously this is going to be a hybrid procedure, but who would go retrograde, who would go anterograde? Let's say retrograde, just in a show of hands. Anterograde? Dr. Amar, if you have any comments, please do at any time. So I decided to go retrograde using the vein graft to the native circumflex, which I think the collaterals are not too bad. If you look pretty, I'm not sure they're quite clear here at this stage. So aggressive guide catheter into the vein graft and just very benign catheter through the femoral artery, 7 French into the left main to hopefully receive the retrograde wire. Microcatheter, escalating retrograde wire, and as you can see, there is a limit where I'm reaching with my retrograde wire. I've managed to reach pretty much close to the ostium of the circumflex into the left main, but none beyond that point. To make things more fun, the microcatheter, I wasn't able to advance it beyond this point. As you can see here, the microcatheter stuck at this point, and it was not possible to advance it despite multiple maneuvers, including using guideliners, using trap balloon, various factors. It was impossible. This is, as you can see, I've put a wire anterogradely into the stump of the LAD, basically just to see if it is possible to advance an IVUS or have a look at guide wire for the retrograde wire to come back. Various attempts, various wires, including Pilot 200, Confianza wire, and Hornet. It was impossible to puncture into the left main. The final one was a Hornet wire, and I wasn't feeling comfortable to go through the left main into the aorta with a Hornet wire without having a clear view where my wire is. So I've used the intravascular ultrasound on the anterograde wire to guide, make sure my retrograde wire is in the true lumen. Luckily it was, and as you can see on the IVUS catheter on the right side, there is 2 wires in the image. Beyond that point, it was impossible to exteriorize the wire into the guide catheter, having seen what we've been faced difficulties-wise, so I decided to put it in the aorta and snare the wire. We managed to get the wire back into the guide catheter using this snare, And just once you are at this stage, you get the wire into the guide catheter, you think you are 90% home and dry. The wire now in the anterior guide catheter, as you can see, then the microcatheter was possible. This is just exteriorizing, was possible to pull it inside the anterior grade catheter and then exchange the wire, and then we have a loop of wires. Now, trying with various balloons, I can't show you all this now. Can we play this, please? With various balloons, we had to use 0.85 to be able to get across on the anterior grade side, and it was like we've used about 20 balloons in order to pass all this chicane. Injecting through this, we start to see an artery which is now, I've probably tortured the artery with the multiple wires and multiple devices, multiple balloons, but we've got the wire in true lumen, so we're home and dry. But you can see a little, if you see a little small leak outside the vessel coming from the point where the microcatheter was struggling to get through. Beyond this point, intravascular ultrasound on the anterior grade channel, first stent to try to seal this. It was 3.5, it's a giant vessel. And the next picture, I'll show you you can see the perforation leak, which is very hard to define where exactly it's coming from, despite the fact it's coming from the stented area. On the IVUS, which I don't have it here on me, it was extensively calcified vessel. For this, so I've used a balloon proximally and then stent to seal into the left main. Yeah, is it too loud? Stent, the proximal stent, while the patient is absolutely fine. And I agree with Dr. Anesi that in bypass graft surgery, perforation could be nightmare in the majority of the cases. Luckily in this case, the patient didn't have any hemodynamic instability. The pocket might be small where it was leaking into, and it was absolutely fine. So proximal stent, IVUS guided, post-dilate, and a cover stent into the old stent to seal the hole. And I'll show you the last picture. This is a trapped contrast inside the small pocket, wherever it is here, and the rest is an open vessel. Now, the message, I'll stop here perhaps. The message from this perhaps is, I think we all agree that bypass graft surgery, to whoever believes that it's the ultimate treatment, there is always patient choice, and the patient choice, rightly sometimes, is the right thing to do. I think PCIing 3-vessel disease for our patients, it's not a wrong decision when the patient doesn't want it. And as you can see, this is a 61-year-old patient who had a bypass graft surgery, and I think the native arteries, as we all seen, they are much harder than native arteries for somebody in his age who didn't have bypass graft surgery. Whether that's true or not, we will never see a randomized trial about these, but it's just the fact that I think we're facing more and more patients post-bypass graft surgery coming for a chronic total occlusion we have to deal with, and we end up with complications like these. Thank you very much. I would stop here.
Outstanding. Thank you very much. Panelist, you want to say a comment, please, on this case, which is, I think, is very difficult.
This is a beautiful case and beautiful result and well-managed complication. Good for you. So I think the comment I want to make is that definitely having bypass grafts aggravates coronary artery disease.
No, absolutely.
And 50% of these patients, when you count them, you'll find CTOs that was not there in the first place. So yeah. I think that's my issue with sending very young patients for CABG, is that when they come back, they have all their vessels are CTOs when the grafts went down. So I think a case well managed. Good for you.
Thank you very much. Yeah, no, I entirely agree that I think we see more and more late outcome following bypass graft surgery. This is not counted in any randomized trial looking at the bypass graft surgery. What happened 10 years down the line to the native arteries for those patients? We talk about criticizing bypass, proximal disease, branches. You talk about many, many disadvantages of bypass graft surgery, yet it's still in the guidelines as a class 1A.
It is my observation here, and I would like to hear from my colleagues if they have similar observation like mine, that patients after bypass surgery, they have kind of aggressive atherosclerosis. The atherosclerosis become aggressive in the other arteries, you know, and even in the arteries that was bypassed, especially in the proximal segment. I don't have explanation for that, but I remember, for instance, a patient before we started doing angioplasty and stenting of the left main, whom I sent for bypass surgery because he has left main LAD, and the right coronary was having just mild lesion, 20% or so. And the patient underwent bypass surgery, and just 1 week after the bypass surgery, he had a non-STEMI, and the right coronary artery was critically narrowed, which was just 1 week before, not more than 20%. What is the explanation for that? I don't understand. But this is my observation, and I would like to hear if you have similar experience in your practice, or this is just mine.
وليد وبعدين آخر. Okay. وليد تفضل.
This is the problem with bypass surgery, and especially when the patient ends up with not full arterialized graft. So he was lucky that this graft is open, and this is a venous graft. The problem is whether this idea is true or not. Well, we know that just we are stealing the flow from the normal artery, make it harder, and affect the endothelium and make it less able to dilate. So that's an acceptable thing. Now, why did you choose to go retrograde rather than?
I think the fact is there is only stump. So anterograde, there is no, it's a very ambiguous proximal plaque as we can see it. I mean, my plan, as always, we always try retrograde, and you try anterograde, you match the two wires. Quite often is the case. In this case, there's had only stump left, and very little to play with in terms of support, wire, whatever you want to use. So starting with anterograde, I think will give you much more hassle than doing retrograde, find a true lumen, and use an IVUS catheter, IVUS guided. That was the plan from the...
Well, that point is well taken, but just with this graft, I really thank you for the courage to go and do all this handling of retrograde through this graft. I accept doing anterograde through the graft, but doing all this retrograde and managing all of that,
I'll tell you what, can I just make a comment? So we presented this case in Europe PCR, and there was one of the comments was on this case specifically is that vein grafts are not all useless. This is, you can use them sometimes. So this is an evidence.
Thank you, very challenging case and nicely handled. I just have a question. What microcatheter did you use, and did you attempt to increase your support or change the microcatheter to get the retrograde micro further down?
Absolutely, it's a great question. I mean, the first one I've used is the Pro one. So it's basically the Asahi one. And as you know, that the microcatheter, they get tired sometimes using in the CTOs, and you have to change it to different one. I've tried to use the Caravelle, which is, there's always a risk in the Caravelle. It can go through the collaterals, usually it's for retrogrades, but equally it's very soft tip, and you can lose the tip easily from the Caravelle. I've tried to use the Caravelle to get across that calcified. It was not even possible. The Turnpike is another option, LP, or you can sometimes use the Gold. However, I'm going into, using the IVUS, it showed how the artery heavily calcified. It looks absolutely dreadful. So using any aggressive microcatheters, I think using the Gold one, LP1, 8, it was just probably shout for more perforation than this.
So we have,
Can we hear from Dr. Omar, one of the master?
we have Omar here, the CTO master.
It's a great case. Personally, I would go antegrade in this case. The reason, I don't know how old is the CTO, how soft or hard, we don't know anything. And also I see that there is some washing from the proximal circ, so maybe there is some blood from the left, the LAD system. So I think we could do triple access to see real anatomy of the CTO, and then we can, after that, I could try antegrade first, and if I wire like you, to LAD or intermediate artery, I think you went intermediate artery maybe, then dilatation, and then maybe I was guided proximal cap penetration. That's also a good option, because this is, this graft, you know, supplies RCA and also CIRC. And I didn't see that much, how is the Lima 2 LED, how healthy. So to me, it's more safe to go antegrade. And most of the time, when you go retrograde, you need to do some antegrade work anyhow, especially for left main work. Most of the time, you need to do some work from antegrade. So in my opinion, I would go antegrade first. But you did a great job.
No, thank you very much. I take your point, absolutely, and I thought about it going antegrade. Yet, as I said, the area, the stump is very short, so the guide catheter will, if you're going to take a deep, obviously you're going to get great support, or you have no option for guide extension. All the options for anterior grade, I think, for this case, may have been, you're going to rely on the wire purely to try to cross this little stump with very minimum space beyond the guide catheter. If I've taken an XP or EBU, the guide catheter will be just wedging the stump, and it may just, from the word go, it may dissect all the way. So that's why my choice was, but I take your point, absolutely. It could have been started from the anterior grade approach, but it was a hybrid approach from the start, so it wasn't just purely retrograde.
Well, thank you very much, Doctor. And I think, I think if you've gone antegrade, no complications case today. No, so
I wouldn't take it. I wouldn't take this one.
I'm just joking. So thank you very much. MashaAllah, yani contribution beautiful, nicely discussed. And we felt what the operator was feeling when doing the case. So inshallah, and have a rest, or what do you call it, a nice night. And see you tomorrow, inshallah, for more cases and more varieties. Thank you very much.